Back to Michael Lumpkin.
Well, I'd like to start off by thanking Michael Kerr and Kathleen Kerr for the invitation to this Bowen Theory Academy session. And so I'm going to be talking largely about stress and its impacts, both physical and psychological. And then I'm going to see how I can weave the stress relationships that exist with the family relationships that exist, and see if we can see how those two things may interact. So I'm pressing the advance button. What did I do wrong?
Just push
Okay.
this one,
Sometimes.
this one,
Okay.
Yeah.
All right.
and push hard.
Sometimes it's getting, sometimes.
Okay, so yeah, as disclosures, I have no conflicts of interest to disclose. I'm not a mental health professional or a psychologist or a psychotherapist, not a medical practitioner. I am married to an anesthesiologist, if that counts. I am, however, a neuroendocrine physiologist and a medical school professor with a particular interest in integrative and complementary medicine, both from a clinical as well as a research standpoint. So I'm going to start off by talking about stress first before we launch into some other aspects of what stress might be doing. And, you know, I like to start off with this jagged kind of distressing stress slide because, you know, when you see something kind of aggressive and unpleasant, you know, you can almost feel that visceral reaction taking place. Michael Kerr talked about this subconscious or this early reaction that we have when there's something unsettling happening and we are not even consciously aware of it. Well, maybe that's what's happening when you look at that slide. And I like to talk about that there are two main types of stress. So just to boil it down to what I think is just the basic, simplest way to think about it, is there's acute stress. This is sort of the everyday aggravations and irritations that we all encounter, the, you know, brief, short-lived challenges that we have to manage every day. And, you know, we get that first reaction by our autonomic nervous system to kind of get us pumped up for it. And it does it just enough so that we can meet the challenge. You know, we will accomplish the task in front of us. That initial acute stress helps us to focus, helps us get the job done. Then it's over with, job completed, and we relax again. And that's kind of the ideal way we would like to have to deal with stress. And this kind of stress is what allows us to survive and thrive for the most part. But then sometimes those acute stressors turn into chronic stressors. They're these challenges and these unpleasant events that just keep coming at us, and they may be long-lived in nature. They could be very intense. And that chronic stress then actually initiates some of those same mechanisms that the acute stress response elicits, but they don't dissipate. At least they don't dissipate quickly and in a healthy way. They just keep persisting. And of course, sometimes when we encounter this chronic stress, it's a situation that we can't remove ourselves from. We don't develop coping skills, and it just keeps coming at us. And that's when it can lead to dysfunction and disease. And although I'm not going to talk about the third item on here about burnout, but just to note that excess chronic stress over a long period of time can actually result in burnout, which basically is when a person just gives up and they just no longer can function because it seems like everything is hopeless. So I like to use this, since I teach medical students and residents in a medical center setting, I like to use this slide as an example of acute stress in a first-year medical student studying for their first medical school exam. So you see the young lady here, this young adult lady, she's focusing on her materials that she's got to study for her first exam. And if you look at, you might even be able to detect a little bit of a smile on her face because she doesn't really know what's getting ready to come at her. So she's used to studying for her undergraduate exams. She's not used to studying for a medical school exam, but she's too naive at this point to understand what's about to happen. So then she goes on through her 4 years of medical school. She goes through, 4 to 7 years of residency training. She becomes a practicing physician. And then all of a sudden, particularly in the current climate that our physicians have to live in, they have to deal with all kinds of issues that are very troubling to them. And this is actually true and serious. So physicians are pressured to see patients as rapidly as possible. You get to have your 10 or 15 minute visit with your doctor. The doctor is forced by the electronic health record system to sit there and type on their computer while they're trying to have a conversation with you and find out what's wrong with you. This is the number one stressor identified by physicians now, is that they hate it. They hate the electronic medical record system because it takes them away from actually being able to interact with the patient in a meaningful way. Then they have to deal with insurance companies. They have to get the permission of the insurance company to do whatever it is they need to do for the patient. They're on the phone with somebody who's an administrator, not a physician, telling them how to practice medicine. That's a stressor. They have to deal with what seems to be like a constant reduction in health insurance reimbursements for their work and declining revenue and salaries. So after she goes through all of that, and now she's in this situation, well, this is her chronic stress response, okay? So she's gone from an acute, naive medical student to now being a very stressed out physician. And of course, anybody can have the same experience, and we all have probably had it at some time or the other. Now, what I noticed thinking about Bowen and the Bowen triangles and the family relationships systems, it always comes back to the triangles. I used the word triad, but I think that the preferred term is triangle. And I noticed that there is this physiological triangle of the stress response that exists. So you see, when stress is imposed on the body, there's a perception by the nervous system, by the central nervous system, that there is the stress occurring. Then information from the nervous system gets transmitted to the endocrine system so that stress hormones are produced. And then the stress hormones will have an effect on the immune system. And then the immune system will communicate back to the nervous system when there's stress present. And we're going to talk about all the factors that allow these three parts of the body to communicate with each other and why that happens. And this system of communication is bidirectional. So it goes in two directions all the way through the triangle. So the immune system is communicating with the CNS. The nervous system is telling the immune system what to do and what signals it should be receiving. The immune system communicates directly with endocrine glands and influences what they're going to be doing. And endocrine hormones, for instance, to give you an example, when your peripheral endocrine glands, whether we're talking about your thyroid gland, your ovary, testis, adrenal gland, they all secrete hormones, and those hormones feed back to the level of the brain to give further instructions to the brain about what it should do. So there is this triangle of these bidirectional communication systems, which of course is reminiscent of what? It's reminiscent of the Bowen theory triangle, where there are these triangular relationships between persons, between family members, for instance. And I'm not an authority on this, you are, so I'm not gonna sit here and explain what the various lines mean, you already know that. But essentially, when discord erupts between two individuals in the system, it's going to cause a third person to be brought into the triangle, and then their interactions are going to take place with that third person that will either intensify or ameliorate the distress that's being experienced by the other two. And then I came across this, where you have these overlapping Bowen triangles, where there are these various dysfunctionalities that may crop up in family members. And these dysfunctionalities can be projected through multiple generations, which of course you all know all of this already. And when I looked at this particular description here of all the things that were happening, you know, strokes and lying and drinking and verbal abuse and affairs and frequent arguments and on and on and on, it reminded me of country western songs where everything is a tragedy in the family and in life. And, you know, there's nothing but these negative events that are portrayed in these country western songs, which I couldn't help myself. I had to add this. Then the dog died and the house burned down. Yeah, I mean, what else could be happening here? Okay. So, but there are some interesting similarities between the Bowen family triangles and the physiological system triangle. So each system has 3 members, obviously. Each member interacts with the other 2 in a bidirectional fashion. A disturbance in one can ripple through to the others. A severe problem in one can cause severe responses in the others, producing imbalances which may actually turn into pathologies in the whole system, thereby undoing homeostasis and disrupting harmony throughout the system. And stress imposed on either system pushes the 2 systems to interact with one another. And typically this results in negative and mutually reinforcing consequences to both systems, to the physiological system and to the behavioral and emotional system existing between the individuals. So to get a better grasp on how these 2 triangles may interact with each other, I want to start by with a discussion of how we perceive stress, okay, and what are some of the consequences of that. Well, the central nervous system is typically the first place that we perceive stressors. The stressors could be internal stressors, they could be external stressors from the environment, but they get processed up at the level of the central nervous system in the brain. And the perceptions of those stressors eventually arrive at that structure that you can see there, the hypothalamus, located here in this interior basal part of the brain. And at the level of the hypothalamus contains some important neuropeptide factors called releasing hormones, also called releasing factors. They're the same thing. And when these bits of information about stress arrive there, they will trigger the activity of these hypothalamic hormones, which, as you'll see in a minute, will govern pituitary hormone secretion. And then those pituitary hormones in turn are going to govern the peripheral endocrine gland hormones, like the adrenal gland output of its hormone. And another thing to note about this, the reason I consider this to be the integrative center of the brain is because not only is the hypothalamus receiving neural inputs from all different parts of the brain, coming from the higher brain, from the cerebral cortex, there are neuronal inputs coming to the hypothalamus from the midbrain. There are neuronal inputs coming to the hypothalamus from the carrying information from the internal organ systems out in the periphery of the body. But in addition to that, there's also blood circulating to the hypothalamus. Now, some of you have probably heard of the blood-brain barrier. You've ever heard of that? Well, at the level of the hypothalamus, around many parts of the hypothalamus, the blood-brain barrier does not exist. So what this means is that anything floating in the blood, dissolved in the blood, can communicate directly with hypothalamic nerve cells that contain these releasing hormones. And so things like peripheral gland hormones like cortisol can get up to the hypothalamus. In fact, all peripheral gland hormones like thyroid hormone also gets up to the hypothalamus. Immune factors called cytokines circulate to the hypothalamus. Metabolic substrates, glucose, free fatty acids, amino acids, their concentrations are being monitored by the hypothalamus. And on and on and on. If it's dissolved in the blood, and it's going to reach the hypothalamus. And the hypothalamus is going to take all that information and it's going to summate it and integrate it, come up with a solution, and the solution is going to be manifested as the release or inhibition of these hypothalamic hormones, which then are going to govern other hormonal events and some other neural events throughout the body. So with that thought in mind, now coming back again to the brain. So as you look at it, just to orient you, if you don't know already, this would be the nose of the individual over here, and this would be the back of the head. And of course, here's the cerebral cortex, that most abundant part of the brain up here. And then as we move into other parts of the brain, over here you would see the temporal lobes that houses the limbic structures of the hippocampus and amygdala. And then where you see the H there, that would represent where the hypothalamus is located. So the reason that I show you this slide is so that you can better appreciate that there is this hardwired, neuronally mediated connectivity that exists between the cognitive brain, the emotional brain, and the autonomic brain. So to be a little more specific, when something happens to us in our internal or external environment and the situation changes, it's perceived by the cerebral cortex. So, and basically the way to think about the cerebral cortex is this the data gathering part of the brain. It's gathering data points and it's collecting all this information. But it hasn't yet put the information into a very usable context at that point. So to do that, the information is gathered up here by the cerebral cortex and it's projected along this pathway here, first into the temporal lobes where you find the hippocampus and amygdala. Now, what's going to happen is now that data is going to arrive at the hippocampus first, and the hippocampus is going to attach a memory function to it. So do these data points look familiar to me? Are they new data points? Do I need to incorporate it into new memory? How does it compare to old memory? And then after that memory function is attached to the information, it's transmitted over here to the neighboring structure, the amygdala, located right here. So then, what's the amygdala's job? The amygdala's job is to attach an emotional response to the information. So you're really now beginning to color the data. You've got memory, now you've got an emotional response. Should I be happy? Should I be sad? Should I be anxious? Should I be fearful about this information that's coming in? Okay, now all that's gathered up into a big bundle of nerve fibers. And in fact, that big bundle of nerve fibers here, although it's not important for our purposes, it's called the fornix, but it's a very thick bundle of fibers because it's carrying all this information. And where is it carrying it to? It's carrying it to the so-called autonomic or vegetative or automatic or the so-called unconscious brain of the hypothalamus. And what's the hypothalamus going to do with it? Well, the hypothalamus is then going to change its output of these hypothalamic hormones that are ultimately going to govern a lot of other hormonal events and also some other neural events in the body. And there are a number of these different releasing hormones or inhibiting hormones. So the main one that we're concerned with today is corticotropin releasing hormone, abbreviated on the slide is CRH. It's a neuropeptide. And then there are other, and in fact we consider CRH the master stress hormone of the body because it's really going to be like the symphony conductor of the hormone stress response in many different ways, and you'll see that in a minute. Then there are other releasing hormones. There's the master sex hormone called gonadotropin releasing hormone that's there. There's also thyrotropin releasing hormone, and excuse me, there are some other ones called somatostatin. Anyway, there's a group of about a half a dozen of these. But you might say that CRH is the first among equals of these releasing factor hormones because it's really CRH, whether it's activated or not activated, that's going to determine whether these other releasing hormones that govern other functions like metabolism and reproduction, for instance, whether they're going to be released or not released. So CRH is in this very pivotal position to govern what's going to happen in response to stress of all different kinds. So then there's this interaction that takes place between the master stress hormone CRH and the two major components of the autonomic nervous system. As you undoubtedly know, there are two branches of the autonomic nervous system. There's the sympathetic nervous system which in general, when stimulated, has excitatory activities to the visceral organs and tissues. And then in a minute, you'll see the parasympathetic nervous system, which does just the opposite. Well, anyway, coming back to the sympathetic nervous system, when stress is perceived by the brain, that message gets arrives at the hypothalamus. That's going to cause corticotropin releasing hormone activity to increase. And another thing that the CRH does is, besides govern hormones, is CRH neurons actually make projections down to the sympathetic centers of the sympathetic nervous system that are located here largely in the midsections of the spinal cord. And so when stress is perceived, it triggers CRH activity, and then those CRH neurons communicate with the sympathetic centers that are located in the spinal cord. And then this triggers sympathetic outflow to the visceral organs and tissues, and so they accelerate, in general, they accelerate their activity, okay, which would be an initial phase of the fight or flight response when one is stressed. Now, in contrast, when we're relaxing, when we're not putting demands on our visceral organs and tissues, then what happens is CRH activity diminishes. And when CRH activity diminishes, this allows more parasympathetic outflow to arrive at the visceral organs and tissues and to essentially tone down their activity. They relax, if you will. So, or another way of looking at this is when we're stressed, when we're stressed and we're putting demands on our sympathetic nervous system, CRH increases its activity and causes that to happen. But then when we relax and the CRH activity goes down, then we inhibit the sympathetic nervous system, but stimulate, or we allow the parasympathetic nervous system to take over. So essentially, stress, by virtue of CRH stimulation, stimulates sympathetic excitatory activity. When you relax, stopping CRH activity stops sympathetic activity and allows parasympathetic activity to take over and cause a reduction in the activity of the visceral organs and tissues. So the point of going through all of that is to show you how corticotropin releasing hormone is not only governing hormonal secretion at the level of the pituitary, but it's also governing the elements of the autonomic nervous system. So once again, an example of how we're going to be developing this integrated stress response. Okay, so I've been throwing the word stress and stressors around, so let's be a little specific about what some of those are. Well, disruptions in sleep, temperature extremes, pain, negative emotions, blood loss through hemorrhage, exercise, low blood sugar of hypoglycemia, infection, trauma, toxins, and also psychological disturbances trigger hypothalamic output of corticotropin releasing factor, which is the same as CRH. And the thing that CRH is most commonly known for is for stimulating the pituitary secretion of ACTH. And so then what is the ACTH going to do? The ACTH is going to cause the secretion of cortisol. Cortisol here is going to cause the secretion of cortisol by the adrenal gland. So what we have going on here with the stress response is we have CRH being released to the pituitary, which is then going to stimulate ACTH secretion, which then is going to stimulate the adrenal cortical output of cortisol. Now, one of the main jobs of cortisol is to function as a glucocorticoid hormone. What does that mean? That means one of its main jobs is to raise the concentration of glucose in the bloodstream in order to make more glucose available to stress-activated organ systems, to provide fuel to those stress-activated organ systems, like the heart beating faster, for instance, or breathing faster. The lungs need more fuel. So it fuels these processes. Now, another job of adrenal gland produced cortisol is to act on the kidney along with some other hormones to retain more salt by the kidney. And by retaining more sodium chloride, and what do I mean by that? I mean taking it out of the urine that's being formed and placing it back into the circulation. It's going to draw water then into the vascular system, into the bloodstream. And in doing that, it's going to increase the blood pressure, which is also a valuable response during a stress response because you want to push more blood to the activated organ systems. So now that activated organ systems have glucose and they have more blood pressure to push that blood and oxygen to them. Now, another thing to be aware of with these rising levels of cortisol as at the end of this cascade of this stress response is that the cortisol is going to act on various tissues in order to further enhance the availability of glucose. So one of the ways it's going to do this is high levels of cortisol, particularly characteristic of a chronic stress response, is going to cause the breakdown of muscle tissue. And what are muscle fibers basically made of? They're made of amino acids. So it's going to release these amino acids from the muscle and put those into the bloodstream. Then those are going to be converted by the liver into more glucose, further ensuring that the glucose levels are elevated. And then another thing that cortisol is going to do is it's going to, act on the liver to convert those amino acids into glucose. And yet another metabolic function of the cortisol is to act on fat cells here to cause the breakdown of the fat, it's called lipolysis, in order to release free fatty acids into the bloodstream. Because free fatty acids can also be used as an energetic metabolic substrate by cells that have energetic demands placed upon them. And then, in the meantime, of course, there's also the activation of the sympathetic nervous system, which is being represented here by the adrenal medulla output of catecholamines, epinephrine and norepinephrine. And so one of their important jobs is to act on cardiovascular tissues over here to cause an acceleration of heart function. They're going to raise blood pressure, they're going to increase the heart rate, they're going to increase the strength and contraction of the heart muscle so it can squeeze more blood into the vascular system and move it to the organs. Okay, and yet there's yet another important function that cortisol has to perform when everything is working correctly, and that is the cortisol levels as they rise in blood are going to negatively feed back at the level of the pituitary and ACTH and at the level of the corticotropin releasing hormone neurons in the hypothalamus in order to instruct them to reduce the further output of those stimulating hormones. Because why? Because after you raise the cortisol, ideally, you want to drop the cortisol periodically back to its baseline. In other words, you don't want cortisol to go up and stay up. It needs some kind of a built-in mechanism to self-regulate. And when everything is working correctly, when the levels of cortisol become high, they will say, okay, that's enough CRH stimulation, that's enough ACTH stimulation, we're done with that. Let's let the cortisol come back to its normal low baseline. Okay, so just to give you a little bit better conceptual picture of this integrated stress response, this is a fairly useful diagram. So stress is perceived, as you can see here at the top of the slide. It's perceived by the central nervous system. That's going to be communicated to the hypothalamus. And the quickest reaction is CRH is going to function actually as a neurotransmitter in this event. And it's going to trigger the sympathetic branch of the autonomic nervous system, that excitatory branch of the autonomic nervous system. And some of the effects of that are going to be to release epinephrine and norepinephrine, those catecholamines, into the blood. And that's going to do things like increase heart rate, increase the rate of respiration, increase blood flow and blood pressure, increased muscle strength and rate of contraction of muscle cells so that you could propel yourself more rapidly in a fight or flight response. Well, as you can imagine, these are all energy requiring processes. So where's the energy going to come from? Well, it's going to come from the slightly later output of CRH to the pituitary. It's going to stimulate the ACTH, which is then going to stimulate the cortisol. And why do you need it to happen that way? Because then the cortisol is going to exert its metabolic effects, meaning it's going to push more glucose and free fatty acids and amino acids into the circulation so that they can be used as energy sources, the glucose in particular, so that activated organ systems and muscle cells have a readily available fuel supply. Now, where things really get interesting, particularly if you're interested in human behavior, is that corticotropin releasing hormone doesn't only act as a hormone and as a regulator of the autonomic nervous system, but it also acts within the brain as a neurotransmitter, acting on other neuronal systems in other parts of the brain, particularly those that govern what you would call stress behaviors. So now we're not talking about stress hormones, now we're talking about stress behaviors that complement and supplement the stress hormone system. So the reason that we know that this is true is because experimentally, when you inject corticotropin releasing hormone into the brain, it increases the locomotor activity, particularly as studied in animal models. So they have stronger skeletal muscle contractions, more rapid skeletal muscle contractions, and they can propel themselves at a faster rate. Also, CRH facilitates the acoustic startle response. So what does that mean? Well, that means that when there's a loud noise in your vicinity, CRH systems, neurotransmitter systems are activated, and they help you to orient to that loud noise because it's a potentially threatening situation. And then number 3 there, it says CRH can produce an anxiogenic-like effect. It can produce a certain level of anxiety. And, normally we think about producing anxiety as being a negative thing. However, in the short term, that brief little bit of anxiety is very useful. So what's one of the most useful things it can do? Well, it helps people to get up and when they're doing public speaking to, get revved up and get going, right? And yet, sure, they're anxious before they do it. Who isn't? Except maybe a sociopath. But the rest of us are anxious. But then, it helps you get started, helps you to get going, and then you get on a roll and things start to go. And you can just imagine how this helps you to focus your attention on the task at hand and to get it done. So a little bit of anxiety for a short time can be useful. And then number 5 here says CRH produces a dose-dependent facilitation of stress-induced fighting. So the way I like to describe this to medical students is, did you ever have occasion to be in a relationship? Party A is with party B, and you think everything's going pretty well, but then something happens and somebody gets pissed off about something. And then, a certain level of disharmony comes about. And did you ever have the experience of the disgruntled party just getting closer and closer, and their jaws are flapping like this, and, they're getting right, and finally they get into your personal space, and you can actually feel the spit coming out of their mouth on your face. And your initial reaction to somebody taking issue with you, at least for most people, is they're a little bit defensive at first. It's like, well, what did I do wrong? Why were you so upset? But then if they just keep coming at you, have you ever had that sensation? It feels like somebody just flipped a switch in your brain, and all of a sudden you go from defense to offense. All of a sudden it's like a sense of rage just comes over you. Well, that's CRH driving your stress-induced fighting response. And you start to have all of these visions of all the terrible things you're going to do to them if they take one more step. Okay, but you can see it in a truly threatening situation where if your last choice is to go on offense, this will help drive that. So, and then number 7 here, CRH produces a dose-dependent taste aversion and place aversion. So I'm just going to talk about the taste for now. So Initial elevations in stress hormones actually drive appetite. You want to consume, I mean, it makes sense, right? You want to consume more glucose because you're under some, an initial set of stressors, but they haven't become chronic yet. But in chronic stress, when you keep CRH activity high for a long period of time in the brain, it acts as an anorexic hormone. It kills appetite. It kills the desire to eat. So I'm sure that as human beings, you've been under the situation where something horrible has happened, and are you hungry anymore? No, not usually. So that's driving that particular feeling that you're having. And then another interesting finding is that in experimental studies and experimental animals, they found that administrations of CRH into the brains of animals could actually mimic the same signs and symptoms of major clinical depression that you see in human beings. So, in human beings, and of course you guys are more acquainted with these than I am, but depressed mood and diminished interest in pleasurable activities, weight changes, sleep disruption, psychomotor agitation, fatigue, et cetera, et cetera, et cetera. So I know all of you guys know what that is, but as you look on the other side of the column, you can see that when they injected CRH into the brains of experimental animals, they could basically mimic many of those signs and symptoms of human clinical depression. So the conclusion is that increases in CRH that are long-lasting in the brain is a major contributor to the development of both anxiety and depression in human beings. And if there was any doubt about that, other studies where they were actually able to measure cortisol and use cortisol as a marker of elevated CRH and ACTH activity, because after all, that's what stimulates the cortisol. They found repeatedly that in clinically depressed patients, they have chronically elevated levels of cortisol. Their diurnal rhythm of cortisol is disrupted in an upward fashion. So you can see that here in the diagram. So normal person, yes, they have that normal 8 a.m. spontaneous increase in the cortisol, and that's what they're supposed to have. But then depressed patients, basically that cortisol profile is elevated throughout the rest of the through that same 24-hour period compared to non-depressed individuals. And that will have consequences. Remember all those metabolic things we just talked about? Well, those might go into overdrive and cause problems. So speaking of going into overdrive and causing problems, so the individual that I'm showing you on the slide has authentic Cushing's disease. So what is Cushing's disease? Cushing's disease occurs when there's excess cortisol output by the adrenal gland. It could be due to an adrenal tumor. In this particular case, it's due to an ACTH tumor that's driving excessive cortisol output by the adrenal gland. And so there are going to be consequences to those ongoing high levels of cortisol in this picture of this authentic Cushing's disease patient. So one of the things that happens is that excess cortisol, you remember how I said it can elevate sodium chloride retention, salt retention, and water retention, and that expands the amount of water in the vascular system, and then that can result in edema, which is what you're seeing in the face there, that swollen face called moon face in this particular instance. Another thing that the high levels of cortisol do is, you remember how I told you it can act on certain fat stores to cause lipolysis and the release of free fatty acids into the circulation? Well, as those levels of free fatty acids in the circulation climb, the pancreas responds by releasing insulin, because the insulin wants to push those free fatty acids back into their fatty storage sites. But basically what happens is, the high levels of cortisol may cause, and if you'll focus on panel C, maybe at first blush you would look at this individual and say, well, that's just an obese lady, she's got a lot of extra body fat. But if it was just your run-of-the-mill obese lady, her buttocks would probably be considerably larger. But what's happening is those high levels of cortisol are targeting the buttocks to cause lipolysis to occur, dump the free fatty acids into the circulation, then the insulin that's released pushes those free fatty acids back into the abdominal fat. And so you get this increase, what's called centripetal deposition of fat. That just means extra fat around the abdomen. And then if you look at panel D, you see down on the abdomen what look like these. You would say, oh, those are probably stretch marks from having babies. No, that's not what those are. That's the breakdown of collagen, a protein-like substance in the skin. It's the breakdown of collagen due to the proteolytic effects of the high levels of cortisol that are present. And so then you get this thinning of the skin, you get the appearance of the underlying blood vessels and tissues, resulting in these purple striae, these purple-looking marks on the abdomen. And then, of course, this person may develop a hyperglycemic situation, excess blood glucose in the bloodstream. She may develop hypertension due to excess sodium chloride and water in the circulation. So these can become very sick in individuals. Now, what's the purpose of going through all that? So with chronic stress, and you keep your cortisol levels high, it can cause many of the same features to develop in patients. They don't actually have Cushing's disease. They just have a chronic elevation in cortisol due to chronic stress response. And some of you may have actually encountered these patients or clients in your offices. If you ever had the thought that maybe somebody that's been under a lot of stress and you know they're coming to you for some help, and you look at them and you know they got a puffy face and they've got extra fat here, and maybe they complain about having high blood glucose and insulin resistance may have developed from that. Has that ever happened to any? You ever look at someone and say, wow, you don't look as good as you used to? Well, they're basically developing this pseudo Cushing's-like appearance. Now there's some other interesting characteristics about corticotropin releasing hormone and cortisol. So have you ever talked to anyone who's gone on high-dose glucocorticoid therapy, high-dose cortisol, cortisone, whatever, for whatever the reason? And there's a couple of things that might have happened. They might talk about when they first go on these things at high doses, some people experience euphoria. Like, wow, I feel the best I've felt in years. And another thing that happens is that they develop a voracious appetite on glucocorticoid therapy. Now, what is it about cortisol at high levels that's going on? Well, also remember that one of the things that cortisol does is it's raising blood glucose levels. And in fact, glucose itself at a high level can feed back to the corticotropin releasing factor neurons and actually act in a negative feedback fashion, just like high cortisol can act in a negative feedback fashion to suppress CRF. So the euphoria that some people experience on these glucocorticoids, when given by, as a medication, they act back here. We'll follow along here. So that cortisol will act back and will may drop the CRH level in the brain temporarily. And with that, they get some acute stress relief. And then another thing that can happen because they're dropping that level of CRH is it's going to result in the increased output of a feeding hormone called neuropeptide Y here. And then you're going to get increased feeding, increased appetite, increased consumption of calories. And you may actually then expand the body fat mass because of this. Now, another thing, have you ever had the experience, or maybe people have talked to you about this? When I'm stressed, I like to eat a nice sugary treat. I want to get those Twinkies and that ice cream and shove them into my yap. And, it actually makes me feel better for a time. Well, one of the reasons it makes you feel better for a time is the elevated glucose which cortisol has pushed up or can push up, whether the cortisol is pushing it up or whether you're ingesting it, that high level of glucose can feed back here also at the level of the hypothalamus and reduce the CRH. And by reducing the CRH, it will actually provide a brief abatement of your stress. You'll actually feel better for a short time. But the problem is, carbohydrates are a short-lived treat. It passes quickly. It gets digested quickly, and then it's gone. And then, you're stressed again. And then you want to eat again because it makes you feel better. Well, one of the reasons it's making you feel better in the short term is because it's temporarily reducing your CRH activity in the brain. And then it's interesting how many disorders are associated with too much cortisol being produced or not enough cortisol being produced. So just to give you a brief overview of this, when you look at where cortisol is high because of what? Because of increased hypothalamic pituitary adrenal axis activity, you can see this in chronic stress, obviously. You can see it in anorexia nervosa. That would be that CRH causing the anorexia. You can see it in what's known as excessive exercise or obligate athleticism. You can see this happening, not surprisingly, in type 2 diabetes. Because why? Because the high cortisol keeps pushing your glucose up, and eventually that can result in insulin resistance in type 2 diabetes. It's a contributor to the central obesity or metabolic syndrome. And it's even high cortisol levels are associated with the premenstrual tension syndrome. Now, where do you see low cortisol levels, and are they players in some of the symptomology of these conditions? So you can see decreased HPA activity with low cortisol in these really difficult to treat conditions. It's basically what seems to happen is people may develop one or more of these situations in this column, but left inadequately addressed, they can morph over into these even more difficult to deal with conditions over here. So for instance, chronic fatigue syndrome. Everybody knows how difficult that is to manage. Fibromyalgia, another difficult to manage condition. Then you have postpartum depression, is you would find low cortisol. In the post-traumatic stress disorder or post-chronic stress, you also find low cortisol levels. And it's believed that basically what's happening is when you go from here to here, in other words, at one time you were putting out copious amounts of cortisol, but what happens is over time, as the deterioration in the body with these more serious or more difficult to deal with conditions develop, the amount of cortisol needed to address those more difficult conditions, you actually develop a relative deficiency of cortisol. Now in the popular press, you sometimes see this called adrenal exhaustion. Okay, you've ever heard that term? So adrenal exhaustion means, so adrenal exhaustion means you have no more cortisol. And that is not a situation that's compatible with life. So you still have some cortisol, but it's not enough to meet the added demands of the body, on the body from these conditions. Okay, so as you look at this diagram, it's over here on the y-axis, it says stress hormone levels, so that's cortisol. And then we're going to look over time. And then what we're going to do is we're going to look at various challenges, various strength of challenges to individuals and how we respond and why we respond. Okay, so with a mild stressor, these are sort of like your everyday aggravations. That could be one way to think about it. Another way might be teenage angst. Okay, so you're the boy and the girl getting ready to go to the prom, and naturally the boy wants the keys to the car or get a limo and put on a big show, and the girl wants a nice dress and doesn't want to look like anybody else's dress. And so, the boy's stressing about the transportation, the girl's stressing about the dress she's going to wear. Is anybody else going to be wearing the same dress, God forbid? So their cortisol levels go up. They go to the prom. Boom. you know, and of course, who knows what happens later in the evening, but in any event, everything turns out okay. Nobody gets pregnant, and the cortisol levels come back down. And that's what we would like to see for every challenge that we encounter in life. We'd like for that cortisol to go up, and then when the problem's over, we'd like for it to come back to its natural baseline. Now, then there are individuals like medical school professors and psychotherapists that have, you know, they have moderate levels of stress over the course of a lifetime. For the most part, you know, yes, our cortisol goes up when we get stressed. And for the most part, you know, it comes back down close to the baseline, not all the way to the baseline. That's just kind of like the wear and tear of, you know, a long career when you have to make a living. So, and that's okay. You know, in general, for most of us, we'll stay relatively healthy that way. And then we have this situation. So there are people, for instance, police officers, combat soldiers, emergency room physicians and nurses, air traffic controllers, that's another one. You know, they do those careers for 20 or 30 years, and it's like constant stress every day at work. I mean, you know, they never get a break, and they just have to keep doing it over and over and over again. And sometimes they can have what we call a severe loss of resiliency. So basically what happens is that the overexposure to cortisol for a long period of time damages and impairs the ability of the cortisol to exert its normal negative feedback and to reapproach its desirable baseline. There's interference with that. So to be a little more specific, naturally we would like everyone to be able to come back to here, but that doesn't happen all the time. So, but the reason we would like it to happen is if we don't return to that baseline, then the sustained high cortisol damages and destroys the neurons that mediate normal cortisol negative feedback restraint on CRH. So then the CRH levels can keep climbing in the brain. And CRH climbing in the brain is going to cause anxiety and depression and behavioral disturbances and disorders to ensue. Then chronic stress with these elevations in cortisol will impair memory and learning due to damage to hippocampal neurons within the hippocampus, where you can actually measure hippocampal volume reduction in people who have chronically elevated stress-related cortisol. And then excess cortisol may cause many of these disturbed metabolic conditions where you develop the hyperglycemia, the high glucose, you get the proteolysis and the breakdown of muscle tissue and bone, for that matter. You can get osteoporosis, and you can get increased fat deposition there in the abdominal region. And then also, the immune system is a target of elevated cortisol levels. So many studies have been done looking at the effects of high cortisol on different immune cell functions. And just about any immune cell function that you can identify, whether you're talking about measuring the levels of blood lymphocytes, or whether you're talking about the production of immune cell cytokines, or whether you're talking about antibody production by immune cells, or whether you're talking about immunoglobulin production, you pick your favorite immune cell parameter, and the overexposure of those cells to cortisol that you get with chronic stress suppresses the immune system. So one of the ways that I like to identify with the medical students and their problems is, you know, so medical students, and I'm sure you as students, you had the same experience. You know, you would have a big exam coming up. You'd study for the big exam. You'd stay up late. You'd eat crappy food. You know, you wouldn't take care of yourself. But yet, you rallied to the occasion. You learned what you had to learn. You took the exam. You did okay. And it was over. But then how many times did you or somebody you knew in your class get sick after that? Get a cold, get a virus, get flu, or or well, who knows what other infection they got. Well, it's because this is exactly what was happening. The cortisol, the elevated cortisol of that stress response was suppressing immune cell protection. Now, where things get really interesting is, what's the most common reproductive disorder in women? Anybody want to shout out? It's up on the slide, actually. It's polycystic ovarian disease or polycystic ovarian syndrome. It's the most common reproductive disorder in females. So one of the things that a lot of these PCO patients share in common is they often have elevated androgen levels, okay? And oftentimes the treatments that are devised for PCO are aimed at modifying either the excess androgens or the inappropriate output of other kinds of estrogen that's not supposed to be there. So, because there are different kinds of estrogens. There's a bad estrogen that's associated with PCO, and there's a good estrogen that you would rather have, which is 17-beta estradiol. Well, in any event, the thing is that probably many of the cases, and probably 50% of the cases of PCO, are probably actually a manifestation of a chronic stress response. And why would that be? Well, let's just follow the sequence of events. So chronic stress increases glucose at the top of the slide there. We already know that because that's something that cortisol regularly can do. Ongoing high glucose stimulates excess insulin output by the pancreas. Yes, pretty much everybody knows that glucose or blood sugar triggers insulin secretion. Well, that ongoing excess insulin that is now a manifestation of a chronic stress response targets cells of the ovary, ovarian stromal cells, and those stromal cells produce ovarian androgens, male hormone, if you will. Well, we don't want a lot of male hormone. We want female hormone, but that's not what we're getting. And the high levels of androgen in particularly severe cases can cause hirsutism, that is extra body hair growth on the female, virilization of the female genitalia in some cases with enlargement of the clitoris because of that androgen. And then finally, amenorrhea, cessation of the menstrual periods, and impaired ovulation, and in the worst case scenario, infertility. So, however, cases of PCO are rarely, if ever, investigated as a manifestation of a chronic stress response. And just for the sake of interest, this is what a polycystic ovary looks like. And by the way, when we're talking about polycystic ovarian disease, we're not talking about ovarian cysts. That's a different animal, okay? So when you, in a real polycystic ovarian disease patient, when you split open the ovary and you look inside, you see all of these little red pump tape appearances. Basically, those are follicles, those are ovarian follicles that are almost to the point of being able to ovulate, but they can't be pushed over into ovulation anymore because of their overexposure to androgen and the production of inappropriate types of estrogen. So now, the gastrointestinal tract is another target of stress. So I'm sure that everyone in this room has probably had some of the experiences I'm about to describe. Now, experimentally, what was done, as you can see on the slide, is various types of stressors, physical stressors, metabolic stressors, chemical stressors, psychological stressors. They were all imposed on animal models. And sure enough, all those stressors elevated corticotropin releasing factor in the brain and in the hypothalamus. And then what that did is that changed the ratio, the correct ratio of autonomic nervous system inputs to the stomach and to the small intestine and colon. And so the outcome of all of that was at the level of the stomach, when you evoke the stress responses governed by CRH, it causes a decrease in stomach contractility and decreased emptying of the contents of the stomach. So in real life, how would we experience this? Well, have you ever been upset and anxious, but you went ahead and ate a significant, quantity of a meal? And then you don't feel that good afterwards if you're upset, if you're already upset about something else. And, it just feels like the food is just sitting there in your stomach. Well, that's because the food is just sitting there in your stomach. It's not going anywhere. Now, paradoxically, at the other end, the way the stress gets manifest, as governed by CRH, is at the level of the small intestine and colon, there's an increase in gut motility. There's an increase in the rate of transit of material through the GI tract. And there's an increased sense of urgency and frequency of defecation. And in fact, in severe cases, you feel cramping. And that can actually develop into diarrhea. And if that goes on for some length of time, you have this stress-induced rapid transit diarrhea that causes the sloughing of the intercellular layer of the gastrointestinal tract to come off. And then what happens is that this allows large food antigens, and by large I don't mean like big chunks of pie, but microscopic, basically microscopic food particles to interact with the immune cells that are embedded in the gut wall, which is not supposed to happen. But when it happens, then the immune cells do what immune cells are supposed to do and generate antibodies to those food antigens, to those food particles, if you will. And then this can become the basis for why people develop food sensitivities or food allergies. So there's this whole crazy sequence of things that can happen that are very unpleasant. And I personally had this experience when I was trying to complete my PhD thesis. All of a sudden, I felt like I had to go to the bathroom every 10 minutes. And, I'd spend time in there, nothing would happen. And then I'd leave, and then 10 or 15 minutes later, I'd feel like I needed to go back again, and nothing would happen. So finally, there happened to be a gastroenterologist in my department at the time, and I told him about it. I said, "What's going on?" He says, "That happens all the time." And he gave me some opiate drugs and, slowed everything right down. Okay. Then, of course, the cardiovascular system is a target of stress, as everybody knows. And high exposure to high stress for long periods of time can have adverse events occur associated with that. So, why does that happen to the cardiovascular system? Well, chronic stress increases sympathetic drive to the blood vessels like coronary arteries and arterioles. So these arteries and arterioles have inside them, if you look at the diagram here, have inside them layers of smooth muscle cells. Okay, so when you're stressed, what's one of the things that you keep activating? You keep activating sympathetic nervous input to these smooth muscle cells. And so what's released there? Well, norepinephrine is released onto those smooth muscle cells. Norepinephrine is released onto those smooth muscle cells, and when they're stimulated, they contract like all muscle cells do. And if you keep doing that over and over and over again, what do all muscle cells do if you keep exercising them? What happens to muscle if you keep exercising it? It hypertrophies, it gets bigger, and it gets more, and the cells become more numerous. So then what happens is the resting vessel diameter is reduced because you've got these thickened smooth muscle cells here, and that results in increasing the resting blood pressure. So then what can happen is if there's a very major life distressing event that occurs, and you get a big dumping of catecholamines onto those smooth muscle cells, you can get a major vasoconstriction, particularly in the coronary arteries, with the loss of blood flow and perhaps even resulting in a myocardial infarction. And another problem with having chronic high blood pressure is if you look over here on an artery over here, you can see that it's developed this plaque. And as you increase the force of blood flowing through there, it can in other words, hypertension can knock off that plaque and cause a thrombosis and a blockage of blood flow to occur someplace critical in the body, leading to death perhaps. And then there is something known about chromosomes, and you've probably heard of these. On the ends of chromosomes are something called telomeres. And telomeres are a part of the DNA that when they're large and they're intact and they're functioning correctly, they actually facilitate cell division. And of course, one of the places you need cell division and cell proliferation is when you have tissues that are dying off or damaged, so you want to replace them, and so you need to have some more cell division to plug the holes. Well, an interesting study was done showing that individuals who were caregivers for chronically ill relatives, when they measured their telomere length, over time, that stress of caregiving of critically ill relatives, the stress of that resulted in shortening their telomeres. And when you shorten the telomeres, you impair normal cell division. And this is believed to be one way that stress accelerates the aging process, is because you can't replace the old tissues with new tissues anymore, new cells. So longer stressor duration is associated with this reduced telomere length and reduced telomerase, which is the enzyme that keeps them intact. So the flip side of this was a study done by Dean Ornish, where he took some patients and he altered their lifestyles and basically low diet, exercise, stress management, group support. But the biggest component was the stress management component. And what he found, to make a long story short, is through stress management, after 3 months of stress management in these individuals, he could increase their telomerase activity, which presumably would increase and maintain telomere length. Okay, so this is a study that goes back to what Mike Kerr was talking about when you were talking about cancer. And it comports exactly with what you and I were talking about, Mike. So this was a study to try and understand what is the role of stress hormones, in this case, epinephrine and norepinephrine, catecholamines of the sympathetic nervous system. What is their role in stress-related cancer? So what they did basically is they took mice, and into these mice they implanted human ovarian cancer cells. That's represented by the blue dot there. So this is the primary tumor cell mass that's implanted. Then they stressed the animal by immobilization stress. They basically tied the mice down to a board for an hour every day. And what they found was that type of stress, which is both a physical stress as well as a psychological stress, caused the tumor cells to metastasize throughout the mouse's body. But what was interesting was there's a stress hormone blocker called propranolol, and if they pre-treated the animal with the propranolol before they stressed it, this would block the metastasis of the tumor cells. And then they did the opposite experiment down here. Basically what they did is they administered a potent stress hormone called isoproterenol. It's like norepinephrine. And that caused a massive spread of the tumor cells throughout the mouse's body. So their conclusion was that stress does not cause a tumor to arise, a cancerous tumor to arise, but once tumor cells are present, it stimulates the spread of those tumor cells through the body. Okay, so another component of this triangle of the stress response, of course, involves the immune system. And so within the immune system, the greatest offenders that push the stress response are what are known as pro-inflammatory cytokines. And you can find these pro-inflammatory cytokines being made by immune cells, macrophages, and lymphocytes that are part of the immune system out in the periphery. But you also find these pro-inflammatory cytokines being made both by neurons and glial cells in the brain. And when they're elevated, and I'm going to use interleukin-1 as a prototype pro-inflammatory cytokine, that IL-1 can stimulate CRH. And then, of course, what CRH is going to do, it's going to stimulate ACTH, and then that's going to stimulate cortisol, and then hopefully there'll be cortisol negative feedback, and not only on the hypothalamic pituitary unit to get feedback, but another purpose of elevating that cortisol in that stress response is to put the brakes on these immune cells that have been stimulated by infectious stress or other kinds of stress, so that they'll stop, reduce or stop producing these pro-inflammatory cytokines over here. So, however, sometimes the stress is so long-lived and intense that it overrides the cortisol negative feedback on the immune system. And so when that happens, when you get excess pro-inflammatory cytokine production, it can provoke autoimmune responses. So you may have heard that some people believe that autoimmunity is caused or exacerbated by stress. And here was one reason why that would be happening. And in fact, there's a cytokine hypothesis of depression. If we'll just go down to the lower entry here, the cytokine hypothesis of depression implies that pro-inflammatory cytokines represent the key factor in depressive disorders. And let's go here. So if we try and put all these pieces together, we could come up with this. And this is based on studies that I did and others did in chronically ill HIV patients. So in chronically ill HIV patients, after they have HIV viral involvement in the brain, their brains start to produce pro-inflammatory cytokines. And pro-inflammatory cytokines by themselves can drive depression symptoms. But compounding the problem is that these pro-inflammatory cytokines, like interleukin-1 is a prototype, stimulate corticotropin releasing factor. And you know how we saw already how CRH can drive the production of anxiety and depression in individuals, which is just compounding the direct effects of cytokines to drive depression. Now, by raising corticotropin releasing hormone levels, and this is where the CRH looks like a symphony conductor of other hormones. When you raise CRH levels in the brain, it inhibits luteinizing hormone releasing hormone, which decreases gonadotropin secretion, that's LH and FSH, which lowers estrogens in females and lowers testosterone in males, with results being reproductive failure and decreased libido, et cetera, et cetera. Another problem with chronically elevated CRH in the hypothalamus and brain is that it suppresses something known as growth hormone releasing hormone, which governs growth hormone secretion. So if you are constantly suppressing growth hormone secretion, you're going to decrease protein synthesis, you're going to decrease muscle mass, you're going to decrease somatic growth in children, you're going to decrease immunity because growth hormone has favorable effects on immune cells, and you're going to decrease wound repair, which of course is something you often see happening in chronically ill patients. And another problem is that CRH is also going to inhibit thyrotropin releasing hormone. That means you're going to have low levels of thyroid stimulating hormone, which means you're going to impair the ability of the thyroid gland to make thyroid hormones. And if you do that, you get a decrease in the basal metabolic rate, exacerbating fatigue and lethargy in already critically ill patients. And of course, CRH stimulates ACTH and elevates glucocorticoids. And what's that going to do? Well, that's going to further reduce immune cell activity, further impairing immunity, making one highly susceptible to further infectious disease. It's also going to decrease protein synthesis and cause proteolysis to occur, causing muscle wasting. And another thing about keeping glucocorticoids elevated constantly is they have direct effects on all these pituitary hormones, on TSH, on growth hormone, on LH and FSH, to suppress the synthesis of those valuable pituitary hormones. So they become deficient. So at the end of the day, with an ongoing chronic stress response, whether it's due to physical disease or whether it's psychological disorders, you can, left in the untreated situation, this can result in major hormonal and organ system impairment, if not failure. Okay, so now that I've gone through all the bits and pieces of the stress response, let's go back to thinking about the triangles for a minute. So, and I would like to acknowledge Victoria Harrison in conversations I've had with her and in work that she's done. She's the one who actually put this idea in my head. So, Victoria, if you're out there, I love you. Okay, so here we have the relationship triangle, the Bowen triangle, I like to call it, in this case, the mother, father, and daughter. On the other side of the page, we have the physiological stress response triangle, the CNS, the endocrine, and the immune. And of course, they're all have this bidirectionality where they're all impacting or influencing or communicating with each other. Now, I'm just going to use an example that I basically put together from what I've learned from Victoria Harrison. So the mother and the mother and father have some kind of ongoing discord. This causes anxiety and stress in the daughter. So that anxiety and stress now triggers her CNS to produce these pro-inflammatory cytokines and corticotropin releasing hormone. And so what's another thing that's going to do? Well, behaviorally, it's going to worsen the stress and depression in the daughter, because that's what these cytokines and CRH do when they're elevated. But furthermore, elevations in the CRH are going to stimulate more cortisol output. And more cortisol output is going to have a negative impact on the immune system and its protections, which may result in the production of more infections in the daughter, if not others that are involved here. And I also would like to add that if a tumor might be somewhere in the body, it might actually contribute to making the tumor grow faster and metastasize. Now, the immune system, the bad cytokines that are going to be being produced, they're also going to have direct effects on the endocrine system to cause more cortisol to be produced and to inhibit the desired production of reproductive hormones. Now, further aggravating that situation, when you elevate CRH, it's going to interfere with the output of hypothalamic gonadotropin releasing hormone. So the gonadotropin levels, LH and FSH, drop, which causes a further decrease in the sex hormones, in this case in the daughter. That's what I'm focusing on. And this could result then in PCOS and infertility. Now, if we come back up here with the daughter-mother interaction, the development of the infertility in the daughter can induce a secondary stress reaction in the mother. It's on top of the ongoing discord stress reaction due to interactions with the father. So now the mother has a subsequent entry into the stress triangle due to the daughter's infertility issues. So then, she gets this all spun up over here on the physiology side. And another issue that can happen as the daughter becomes more depressed and perhaps infertility becomes a more or less permanent issue is the daughter's husband's triangles are triggered. I didn't have room to put more triangles on, so I'm just calling it that. So you can see, I think you can get the idea how these two things can just start to feed on each other and just spin each other up into a frenzy. And okay, so there you have it. Everything is bad. Well, I don't want to leave you with the thought that everything is bad. So I thought I'd put in something positive. So that brings me almost to the end. When there's an anti-stress hormone called oxytocin. Probably most of you have heard of it. Anybody that's probably delivered a baby has heard of oxytocin. So the oxytocin is the anti-stress hormone. And why is it the anti-stress hormone? Well, because it pretty much does exactly the opposite things that corticotropin releasing hormone, and pretty much the opposite thing that the pro-inflammatory cytokines do. So what I'm imagining is when you Bowen therapists are helping patients, helping clients. You know, you teach them how to have more positive social interactions, which enhances their oxytocin release, which then further causes more positive social interactions, also causes reattachment, rebonding to family members, and effective emotion regulation results from that. And when you improve your effective emotional regulation, then you get more oxytocin release, which is going to act as an anti-stress agent in the body. Because why? Because oxytocin can directly interfere with the stress-producing actions of CRH and ACTH. Okay? So, I'm asking a question. So with Bowen theory and Bowen psychotherapy practices, is this a path to breaking the mutually advancing functions with triangular dysfunction and restoring homeostasis? In other words, is when you practice Bowen therapy, are you actually, and of course, you know, when you have a hammer, everything looks like a nail. That's what I'm a neuroendocrinologist, so that's my hammer. So is it when you're, doing these psychotherapy interventions and they're successful, is one of the things that you're actually accomplishing from a neuroendocrine standpoint, are you causing more oxytocin release to occur so that you can improve emotional functioning, improve social functioning, improve cognitive abilities, and improve the neuroendocrine effects of previously being run down by excessive CRH. So I'll leave you with that thought. Thank you.
So we're going to break, and then we'll have the panel. What time do you want them back? What time do you want them back?
Well, 2:55.
What time do you want them back?
It was supposed to be one.
Margaret goes next.
Yeah,
No, there's a break.
there's a break.
Yeah, no, I mean after.
Right. Margaret goes next. All right, so we will come back in 10 minutes. No, 15 minutes. Let's come back at 3. Is that what it is? Okay.
We're a little bit over, Lonnie.
What will be that be too far over?
I think we should maybe 2:55.
2:55.
Yeah.